Good morning. This is Dr. McDaniel. It's Wednesday, Hump Day, June 12th, and as the title indicated, I will be continuing the information on postmenopausal bleeding or bleeding after menopause. So if you look at the presentations for more details on different sections from earlier this week, that will provide more complete information. I'll try to give a fairly brief overview and then hopefully be able to conclude the information today. So postmenopausal bleeding is any type of bleeding, be it pink, brown, smudgy, black, burgundy, bright red, light, spotty, or heavy, doesn't matter. Any kind of bleeding that occurs after one has gone through menopause. And menopause is defined as not having had a menstrual cycle for 12 months or more in the face of hormones that confirm a menopausal state of the ovaries and or menopausal symptoms. So the evaluation for postmenopausal bleeding is to do an exam to confirm that the bleeding really is from the uterus. It's not from hemorrhoids or ulcerations or cuts, sores, polyps, masses or growths in the vaginal cervical environment, and then to confirm it's not due to infection. So chlamydia, gonorrhea, and a urine culture are obtained. Chlamydia and gonorrhea will, if present at all, will be present in the bladder, urethra. It's very unlikely to be present in the cervix of a postmenopausal woman. After that, it would be hormone evaluation to confirm that the bleeding really is due to a postmenopausal sources or etiologies, and to confirm it's not due to a medical condition. Second to last would be an ultrasound or a sonogram to confirm that the bleeding is not due to a physical or grossly visible or macroscopic mass, tumor, tissue aberration, abnormal buildup inside the uterine lining. So the lining of the uterus, we call that the endometrium. That lining, if one is menopausal, should be 3 millimeters or less. And on the ultrasound, we call that the endometrial echo. If a lady is taking hormone replacement, systemic hormone therapy, then we allow for 5 millimeters or less. If the lining inside the uterus, that endometrial echo, is measuring thicker than 3 or 5 if someone's on hormone replacement millimeters, then further evaluation is warranted. If it's very, very clear that it's just globally homogeneously thickened, then an endometrial biopsy should be obtained. If it looks like there's a question, it looks like it's difficult to ascertain, or that there's potentially a mass or an unusual finding, then further evaluation could be obtained with a specialized sonogram where fluid is instilled in the uterus to open the cavity and better delineate any focal abnormal masses or growths. That's called a saline infusion sonogram or a sonohistogram, or potentially an MRI, a magnetic resonance imaging study, could be obtained to evaluate if there's infiltration or spread into the muscles or the meat of the uterus, or if there's abnormal blood supply, to give a little bit more detail on the physical structures. If it's pretty obvious that's just a thickened endometrial lining, then a biopsy is obtained. If the other studies are obtained and it confirms that there's global thickening or that there's a focal thickening, then either a biopsy in the office, which is called a blind biopsy, the endometrial biopsy, or a dilatation and curettage, the DNC, is obtained in order to obtain that tissue to send to pathology for a diagnosis. Or if it looks like there's a focal finding or something suspicious that may look malignant, then the patient should be brought to the operating room, where under direct visualization with a camera, which we call a hysteroscope, that tissue can be completely removed. That procedure is a day surgery procedure, and it's called a dilatation and curettage, or DNC, with hysteroscopic evaluation and potentially polypectomy or myomectomy or whatever additional work is deemed necessary. The reports from the pathological evaluation can be varied, But essentially, the question is, will it say that there's inactive endometrium? So that means it's just a little bit of thickened tissue, thicker than our parameters allow, but it's menopausal state because there isn't any hormonal activity occurring, so it's inactive endometrium. There's nothing to do but just to monitor the patient for further bleeding, or to repeat the sonogram in 6 months to confirm it's still stable. It could potentially come back as endometrial hyperplasia. Hyperplasia means hyper, over, and plasia, to make, so the tissue is built up, it's overly thickened, and it's the normal tissue that we see in a non-menopausal state, so in a proliferative phase, to cause a period to come, but obviously that's not supposed to happen because she's menopausal and it's thickening up. So in the case of endometrial hyperplasia, we have a variety of categories. If it's simple, nothing worrisome, we just give her progesterone, which is the hormone that causes a menstrual period. It cleans out the uterus. We'll give her progesterone to clean out the uterus. Usually we'll do that for 3 months, do a follow-up sonogram or a follow-up biopsy. Or it could be hyperplasia with abnormal changes. Depending on the degree of changes, she would need to either have the same story, high-dose progesterone given and then a follow-up biopsy, or taken to day surgery and have, under direct visualization, a full clean out or curettage done to completely assess all of the tissue. If it says that there's complex hyperplasia and it looks like there are precancerous cells or adenomatous changes, then she's definitely brought to day surgery for a complete clean out and evaluation, and then high-dose progesterone therapy ensues. Sometimes it will come back as polyps. Polyps are abnormal balls of blood vessels. If she has polyps, then those should be removed under hysteroscopic evaluation also, so a camera completely removed, sent to pathology to confirm the polyps are benign and not cancerous or precancerous. And then no further treatment needs to be done, but just a follow-up sonogram in 6 months to confirm she's stable. It could also come back as inflammatory changes due to an infection, so chronic infection or inflammation, then antibiotics are usually given, follow-up sonogram or monitoring for bleeding. Or it could potentially come back asynchrony. Asynchrony means that she has a patchy, irregular buildup. So some areas in the uterus look like they're menstrual, other areas in the uterus look like they're menopausal, other areas in the uterus look like they're post-menstrual or after the menses. So then again, progesterone therapy is given to chemically try to keep the lining cleaned out and thinned, and then a follow-up sonogram is done. So that's a really quick overview on the evaluation, diagnosis, treatment, and management of postmenopausal bleeding or bleeding after menopause. So I hope that's been helpful to everyone on that topic. This is Dr. McDaniel at GYN Corner on Facebook. Also check out our YouTube page. I started the YouTube page last month also. It's also called GYN Corner. And I'll be back tomorrow morning with a new topic. Thank you for watching. Have a great day.